Hello and welcome to all of you. A very good evening to all of you. We people have come here for this pharmacology discussion. So, we have today's part one of pharmacology. So, I am there with you on your Telegram group. So, in case, guys, you people have any doubt, you can directly post a query on this Telegram group. So, I would happy to answer your queries. The name of the group is Test and Discussion 2024. So Test and Discussion 2024 is a Telegram group where you can post your queries in case you people have any doubt. So I'm Dr. Saurabh Bhatia and I'm your pharmacology guru here at DBMCI. So in case any one of you are online, can you please confirm me about my audio and video? Audio video quality all fine or not? So the group name is Test and Discussion 2024. In case you people have any doubt, you can directly post over there. But before that, it would be great in case you people confirm me about the audio video quality. So audio video quality all fine. Are you people able to listen to me clearly? You people are able to see me clearly? Yes or no? If you will give me yes, then okay, we can go ahead. Yes, Dr. Pranav, very good. Yeah, good afternoon, Dr. Pranav, Dr. Pranav Vadvan. Okay, so yes, Dr. Sneha, thanks for the confirmation. I was waiting for the confirmation that somebody will confirm me. Yes, thanks for the confirmation, Dr. AB. Yeah, thanks, Pranav, AB, and Sneha. Thanks for the confirmation. So, guys, we are going to start with this pharmacology paper one. So, question number one. So, question number one is a controversial question which was asked in your INSCT exam. So, in your INSCT exam, this question was asked 2 years back. So, which of the following receptor associated with opening up of potassium channel without involvement of secondary messenger? So they are asking a name of a receptor which does not require a secondary messenger but still open up the potassium channel, right? So open up the potassium channel but without the involvement of secondary messenger. So what can be the answer of this question? Anyone can answer. So guys, the controversy here is there are two answers which are possible here. This question was asked in AIMS exam. There's a controversy. The controversy is both can be the possible answer. Muscarinic 2, muscarinic 2, muscarinic 4. So both answers are possible. So both answers are possible, but because muscarinic 2 receptor is more studied in detail and we have more studies available uh, with the working of muscarinic 2 receptor. So here you will give preference to muscarinic 2 receptor over muscarinic 4. So here the better answer is muscarinic 2. So better answer is muscarinic 2. Overall answer is muscarinic 2. Right? So question number one, answer is B, Bombay. So this question is based on G protein coupled receptor. Yes or no? So this is based on G protein coupled receptor. So if we talk about G protein coupled receptor, you people have to give me the answer. Number one, what is the shape of G protein coupled receptor? So if I ask you this question, what is the shape of G protein coupled receptor? So it will be great, like in case guys, you people interact during the lecture. So my question is, what is the shape of a G protein coupled receptor? So the shape of a G protein coupled receptor is, anyone would like to answer? What is the shape of a G protein coupled receptor? So we have a receptor, we call it GPCR, G protein coupled receptor. What is the shape of the receptor? So here the shape of the receptor is serpentine receptor. It's a serpentine receptor. The shape is like a snake. Snake in Sanskrit is known as Sarp. So Dr. Pranav and Soma Shubhra have given the correct answer. Dr. Sneha, very good. Now guys, in this serpentine structure, we have the presence of helix. Now who will tell me how many helix are there? How many helix are present in the structure of this G protein receptor? Second question. Third question, what is the active form of this receptor? What is the active form of this G protein? So if I ask you this question, what is the active form of G protein? Is it GDP or GTP? What is the name of the active form of G protein? GDP or GTP? So how many helix are there? First question. Second question, what is the form of G protein which is considered as the active form? Very good. Dr. Nitin, Soma Shubhra, Sneha has given the correct answer. It's a 7 helical shape. So the receptor is 7 helical shape and it's a G protein receptor. So G protein is present in this receptor to have the action. So what is the active form of G protein? So what is the name of the active form of G protein? GDP or GTP? So the answer is, yes, the answer is GTP. Dr. Pranav has given the correct answer. So GTP is the active form of the drug. So the active form of the drug is GTP, but when this receptor become inactive, this becomes GTP. So this becomes GDP in its inactive form, and whenever the drug will act on its receptor, the receptor will acquire the GTP form. So a receptor will acquire the GTP form, and this receptor become active. So active form of the receptor is GTP, right? Now when this receptor become active, the active form is G alpha. So G alpha gets separated from the beta gamma. So when this receptor become active, G alpha gets separated from the beta gamma. So beta gamma is not important for the exam, so we don't study beta gamma in detail. So we only concentrate on the G alpha. Now this G alpha can be of three types. The G alpha receptor can be of three types: G alpha S, G alpha I, and we have the G alpha Q or not. We have three types of receptor: G alpha S, G alpha I, and G alpha Q and not. Three types of receptors are there. So G alpha S is stimulatory. So whenever this is a subtype of G protein receptor, this is activated. This will activate one enzyme. The name of the enzyme is adenyl cyclase enzyme. This will activate adenyl cyclase enzyme, which is in the presence of ATP. In the presence of ATP, this will result in increased level of cyclic AMP. This will result in increased level of cyclic AMP and will activate a protein. We call it protein kinase A. One enzyme is activated, we call it protein kinase A. And this protein kinase A will result in stimulatory action. This is the one that is responsible for stimulatory action in the body. Now G alpha I is the one which is just opposite. This will inhibit adenyl cyclase, reduces cyclic AMP, reduces protein kinase A, and can result in inhibitory actions in the body. This will result in inhibitory actions in the body. Here the cyclic AMP. Here the cyclic AMP will act as a secondary messenger. So this is a secondary messenger which is present over here. Cyclic AMP will act as a secondary messenger. So both subunit will act with the help of a secondary messenger. We call it cyclic AMP, right? But guys, apart from this action, these receptors also work without the involvement of secondary messenger. For example, G alpha S is the one. G alpha S is the one that will directly open up the calcium channel. Can result in calcium influx. And responsible for stimulatory action in the body. So this will directly open up the calcium channel, can result in calcium influx, and can result in stimulatory action in the body. And similarly, G alpha I. G alpha I also act directly by opening up of potassium channel. So this will act by opening up a potassium channel. So potassium channel will open up, and when this potassium channel will open up, potassium will go outside the cell. So potassium efflux will take place, and when this potassium will go outside the cell, this will lead to inhibitory action in the body. So this will result in inhibitory actions in the body. So G alpha I will open up the potassium channel, can result in inhibitory action. G alpha S will open up the calcium channel, can result in stimulatory action. So these two actions are independent of the secondary messenger without the involvement of the secondary messenger. Now if we talk about G alpha Q and not, they will activate phospholipase C enzyme, right? So they will activate phospholipase C enzyme. This will result in increased level of a secondary messenger. We call it IP3-DAG. So this is a secondary messenger which is present over here. This will increase IP3 and DAG level and can result in increased level of calcium. And here the calcium will act as a tertiary messenger. And finally the action will take place in the body, and most of the time this action is related to the muscle contraction. This is how these different types of G protein will act in the body. So this is how the different types of G protein subtypes will act in the body. So calcium will act as a tertiary messenger in respect of IP3 and DAG. Now guys, if we discuss the different examples, what are the examples of the receptors which are stimulatory type of receptors? So here you have to remember the examples of the receptors like beta 1, beta 2, beta 3. So beta 1, beta 2, beta 3 are the stimulatory type of receptor. Second example of stimulatory receptor is dopamine 1 receptor. Third example of cyclic AMP receptor is histamine 2 receptor, vasopressin 2 receptor. So histamine 2 receptor, vasopressin 2 receptor, D1 receptor, beta receptor, beta 1, beta 2, beta 3. Now we talk about the inhibitory actions. If we talk about the inhibitory actions are due to the inhibitory receptors. Inhibitory actions are due to the inhibitory receptors. So we have the inhibitory receptor like alpha 2 receptor, muscarinic 2, muscarinic 4 receptor. So alpha 2, muscarinic 2, muscarinic 4 receptor. We have opioid receptors like mu, kappa and delta. We have the opioid receptors like mu, kappa and delta, and we have one serotonin receptor 1. So serotonin receptor 1 is also a type of inhibitory receptor. So these are the examples of inhibitory receptors in human body. Now, what are the receptors which are present over muscles? Because these receptors are involved in smooth muscle contraction. So, which receptors are involved in smooth muscle contraction? We have the receptor like muscarinic 1, 3, and 5. So, muscarinic 1, 3, and 5 are the type of contractile receptor. They will result in contraction in the body. Similarly, we have the angiotensin 1 receptor. So, angiotensin 1 receptor is one more example of receptor that is associated with IP3-DAG activity. One example of inhibitory receptor is dopamine 2 receptor. So dopamine 2 is also a type of inhibitory receptors. Now guys, all these receptors which we have covered over here, these receptors are important for your exam because there are some drugs which you should be knowing that will act on these different types of receptors in the body, right? So we can say that the receptors that will act without secondary messenger and that will open up potassium channel directly, it is a muscarinic 2 type of receptor, right? Now, apart from this, guys, if I talk about the nicotine receptor, one more receptor which is given over here is a nicotine receptor. Now, please remember, nicotine receptor is the one which is a type of ligand-gated ionic channel. This is not a receptor associated with secondary messenger. It is a ligand-gated ionic channel. So this is a type of ionic channel. It is not, this receptor does not require any G protein. This is only involved with movement of the ions. So this nicotine receptor can be of two types. This nicotine receptor is the one that is present on muscles. So if it is present over muscle, we call it NM. And if this receptor is present over nerve, we call it NN. So the receptor present over muscle, we call it nicotine muscle type. If the receptor is present over nerve, we call it nicotine neuron type, right? So there are two type of receptor. Now this nicotine muscle type of receptor, this is present over our skeletal muscle. So this is the receptor which is present over all skeletal muscles of the body. So all voluntary muscles of the body, we have the NM receptor. The junction is known as neuromuscular junction. Now this receptor is pentameric in shape. This receptor is pentameric in shape, having the 5 subunits. So in the shape of the receptors, we have the 5 subunits. If I draw the 5 subunits, I will draw the 5 subunits like this way. So these are the 5 subunits of the receptor. In the center of the receptor, the sodium ion will take entry. So sodium will go inside. This is present in the central pore of the receptor. Like if I draw the receptor in a vertical structure, if I draw the receptor vertically, then I will say the receptor is like this way. So here how the sodium will take entry. So sodium will take entry whenever the receptor will open. The same structure I have shown in a horizontal view where I have drawn the 5 subunits for you. Right. Now they will ask you the names of these 5 subunits. So what are the names of these 5 subunits? The names of these 5 subunits are alpha 1. The second one is beta. The third one is again alpha 1. The fourth one is delta. Then we have the gamma. So we have alpha 1 beta, we have alpha 1 delta, and then we have the gamma. Now the next question will be asked to you, where the acetylcholine, which is a ligand of this receptor, where the acetylcholine will come and bind to the receptor. So please remember, this is the binding site. This is the binding site of acetylcholine. So acetylcholine will always come and bind over here, that is on the NM receptor, and can result in muscle contraction. So we can say that acetylcholine binding site is interface of alpha 1 beta and interface of alpha 1 delta. So this is the binding site of acetylcholine, alpha 1 beta, alpha 1 delta. Students, make the mnemonic like this way: after breakfast, after dinner. So acetylcholine binding site is after breakfast, after dinner. It's not gamma. And again, I'm repeating the word. It's not gamma. It's alpha 1 beta, alpha 1 delta. There is no gamma. Here, the acetylcholine will come and bind. Now guys, we have the drugs which are blocker of this receptor. Those medicines are ends with the word curium. So medicines which are known as skeletal muscle relaxants. Skeletal muscle relaxants are the medicines which end with the word curium or curonium. So curium and curonium are the medicines which end with the word medicines are the skeletal muscle relaxants. Now same are the binding site of these medicines. So whatever are the binding site of acetylcholine, same are the binding site of curium and keronium on this receptor. So they are the competitive inhibitors. They are the competitive inhibitors of NM receptor. They will not let acetylcholine to bind on this receptor by occupying the sites which are alpha 1 beta, alpha 1 delta. Got it? Now, if we talk about nicotine N receptor, now nicotine N receptor present over neuron. So this receptor is maximally present in our central nervous system. So this receptor, which is present over nerves, the nerves are maximum in CNS. So this receptor is maximally present in CNS. Now, you people have to remember the name of one nicotine N receptor. We call it alpha 4 beta 2 type. So you have to remember the name of a nicotine N receptor, which is alpha 4 beta 2 type. It means in the structure of this nicotine N receptor, which is also a pentameric in shape. This is also pentameric in shape. It has alpha unit. The name given is alpha 4. So the name given to alpha unit is 4 and the name given to beta unit is 2. There is no gamma, no delta. Here we don't have any gamma or delta. We have only alpha and beta units that are present 3 and 2 times. Total become 5. Now, why this particular center of the brain is important? Why this particular receptor is important? Because this is the receptor which is involved in nicotine addiction. So this is the receptor that is involved in nicotine addiction. So whenever we have to make any patient de-addicted, whenever we have to make any patient nicotine de-addicted, we always exploit the receptor that is alpha 4 beta 2 type. So if the question is asked to you, which medicines will act over here? Which medicines can act on nicotine and receptor? So guys, we use nicotine skin patch. For nicotine de-addiction, we use nicotine skin patch. So nicotine that is present in the skin patch will come and bind over here. Right? Similarly, we have a drug Vernicline. We have one more medicine. The drug name is Vernicline. So Vernicline is a drug that is having the word NIC in its name. This medicine is having the word NIC in its name. So this medicine is a partial agonist of this receptor. So Vernicline is a partial agonist. Vernicline is a partial agonist and nicotine is a full agonist of this receptor. So this receptor is important for your exam point of view. Right? So this is a receptor that is associated with sodium, not the potassium. Nicotine receptor associated with sodium, not the uh, potassium. That's why answer to this question is not potassium. They're asking which receptor. Now read the question again. Which of the following receptor associated with opening up a potassium channel without the involvement of secondary messenger? So here the answer is the inhibitory receptors. The G protein couple receptors, which are inhibitory type, they can open up the potassium channel directly without the involvement of secondary messenger. So best possible answer is Mustanic 2. Difficult question, but fine. Like it was asked in our INSCT exam, so we should respect our examiner the way they put the question. Right? Now, question number 2. The second question is regarding ACLS protocol. So, ACLS protocol is Advanced Cardiac Life Support. So, Advanced Cardiac Life Support protocol. What is the starting dose of atropine? So, what is the starting dose of atropine in treatment of bradycardia? What is the answer, guys? Which answer you people have marked? What is the answer you people have marked here? ACLS protocol. What is the starting dose of atropine that we use in treatment of bradycardia? Anyone would like to answer? Arey, after question 1, you people have gone. Priyanshi, Nitin, Somashubhra, Sneha. Somashubhra, your name is wonderful. Like, I really liked your name, Somashubhra. Okay, so the answer is 1 milligram. So here the answer is 1 milligram. So starting dose of atropine is 1 milligram. So initially, guys, it was 0.5 milligram. Up till 2017-18, it was 0.5 milligram, but it is increased to 1 milligram. So atropine dose is increased to 1 milligram. So question 2, answer is C. Question 2, answer is C. So this question number 2 is based on ACLS algorithms. This is based on ACLS algorithm. So guys, we have total 4 algorithm. The first one is CPR algorithm. So one is CPR algorithm that you will cover in your anesthesia class, like how to give CPR to a patient. Apart from this CPR, we have 3 more algorithm of ACLS. One is known as the one algorithm is of bradycardia. One algorithm is of tachycardia. So one algorithm is of bradycardia, other algorithm is of tachycardia, and one algorithm belongs to cardiac arrest. So total we have 4 algorithm of ACLS. We call it advanced cardiac life support. Right? One is of CPR, how to give CPR, that you will cover in your anesthesia class. Now we talk about the bradycardia. Right? So guys, whenever patient heartbeat is less than 60, whenever patient heartbeat is less than 60 associated with symptoms, patient require treatment, or when the patient heartbeat is less than 50 beats per minute with or without symptoms, we have to treat the patient. Right? When the patient heartbeat goes less than 60 with symptoms or less than 50 with or without symptoms, we need to treat the patient of bradycardia. And what is the drug of choice? The drug of choice for bradycardia is atropine. And whenever we have to give atropine, the starting dose of atropine is 1 milligram. The starting dose of atropine is 1 milligram. Maximum dose that we use in a patient is 3 milligram. So starting dose 1 milligram, maximum dose that we can use in this patient is 3 milligram. So atropine, starting dose 1 milligram, maximum dose 3 milligram given to the patient. But even after giving 3 milligram, patient disease is not controlled. So here the NC means patient disease is not controlled. Then we can add the other medicines which will directly stimulate the beta 1 receptor. So medicines that will directly stimulate beta 1 receptor, this medicine can be dopamine, this medicine can be adrenaline. So adrenaline or dopamine are the second medicines that we can add in the patient treatment of bradycardia if atropine maximum dose 3 milligram is not able to control. Right? Now let's talk about the second thing, the cardiac arrest. So whenever the patient has come to us with cardiac arrest, how to manage a patient of cardiac arrest? So in patients of cardiac arrest, there are two types of presentation. So patient can have two types of presentations in cardiac arrest. Number one, so patient can come to you with shockable rhythm. So patient can come to you with shockable rhythm, or patient can come to you with non-shockable rhythm. So patient can have shockable rhythm, patient can have non-shockable rhythm. So the patient has come to you with shockable rhythm. If the patient has come to you with shockable rhythm, that is of cardiac arrest. So what are the examples of shockable rhythm? The patient can come to you with ventricular fibrillation. Patient can come to you with pulseless ventricular tachycardia. So patient can come to you with ventricular fibrillation, or patient can come to you with pulseless ventricular tachycardia. So here we give the medicine. Here we start. Here we go for the shock first. We try to synchronize the patient by giving the shock, and immediately after shock we do the CPR. So we give the shock followed by CPR. This is done 2 times. But even after doing 2 times, patient is not controlled. Patient is not revived. The better word is patient is not revived. After giving the shock and doing the CPR 2 times, then we have to give adrenaline to this patient. We have to give adrenaline to this patient as a drug of choice for this type of shock. That is a uh, that is cardiac arrest. Now, what is the dose of adrenaline? Few people have to answer me this question. What is the dose of adrenaline that we have to give? What is the concentration of adrenaline that we use? Right? What is the volume of the drug that we will inject in the patient body of the drug? And what is the route of administration? So, 4 questions you have to answer me. Whenever we have to use adrenaline in a patient of an cardiac arrest, what is the dose? What is the concentration? What is the volume? What is the route of administration? So these things you have to answer. Now, after understanding these different routes and different things, if the patient is not revived, so even after giving adrenaline, patient is not revived. So even after giving adrenaline, patient is not revived. So till so far, the questions answers, 3 students have given the answer and all 3 have given the wrong answer. All 4 have given the wrong answer. This is the beauty of the, the concept. You know? Like all of you have given the wrong answer, guys. Try to uh, recollect, like what can be the dose of adrenaline. So all of you have given the wrong answer. No, no. Fifth student also has given the wrong answer. Sixth student has given the correct answer. Dr. Nitin, your answer is partially correct. Nitin, the answer is partially correct. Yes. So here, the guys, the dose is very high. We will give 1 milligram dose. Can you imagine? We will give 1 milligram dose, and the dose which you people are writing, look at the dose you are checking. Check the dose. Like someone has written 0.1, someone has written 0.5. So the dose is very high. It's 1 milligram dose because the patient is almost gone. So patient is almost gone, right? So patient is almost gone. The dose is 1 mg. The concentration of drug that we will inject in the patient body is 1 is to 10,000. Concentration is 1 is to 10,000 and the volume of the drug is 10 ml. 10 ml is the volume of the drug that we will inject in the patient body. Guys, the volume is 10 ml. You have to see like this way. Like this is the preparation that we need to give to the patient. If you can see this photograph. So guys, if you see this photograph, you can see we have to give total dose of 1 milligram. So 1 milligram dose is present in 10 ml of the liquid. So in this 1 is to 10,000 preparation, 0.1 milligram drug present per ml. So per ml, we have 0.1 milligram drug and total dose we have to give 1 milligram. So how many ml we have to inject? So answer is we have to inject total 10 ml. So total 10 ml we have to inject. And what is the route of administration? So only one student has given the correct answer. We have to give medicine by IV route. We have to give medicine by IV route, but in this case, even the superficial veins are also collapsed. Superficial veins are also collapsed. So we have to give medicine by intraosseous route. We have to give the medicine by intraosseous route. So we have to give the medicine by intraosseous route, so intravenous or the intraosseous route. Now the question is asked to you, whenever you have to give medicine by intraosseous route, whenever we have to give medicine by intraosseous route, then which bone is used? In which bone we will inject the medicine? In which bone we will inject the medicine? Anyone can answer? So which bone is used for intraosseous route? Can any one of you give me the answer? Which particular bone we use whenever we have to give medicine by intraosseous route? कोई है यहाँ पे जो आंसर दे सकता हो इस क्वेश्चन का? So the medicine are given by So I'm trying to find out a photograph for you, but I'm not able to do so. No problem. Uh, we'll discuss over here only. Sometimes whenever you try to find out an important thing, everything else you will find, but not the most important thing that you want. Anyways, no problem, guys. We'll come back. So yes, so we will give medicines in tibia. We will give medicines in tibia, and in adult patient, we can use any end of tibia, but like Dr. Sneha Jha has mentioned already, like we always use the upper end of tibia in pediatric patients. So in pediatric patient, I wanted to show you the photograph of the X-ray, but it's fine. In pediatric patients, in the lower end of tibia, we have the presence of epiphyseal plate, which is not fused. So in children, epiphyseal plate is not fused. So in case you want to try to give medicine in the lower end of tibia, there is a risk that epiphyseal plate get damaged. And if the epiphyseal plate is damaged and the child is revived, then the child leg length, the lower limb length will not increase. The length of the lower limb will not increase because of the injury to the lower end of tibia. So in children, we always use the upper end, but in adult patient, we can use any end of tibia. Now, if the patient is not revived, so patient is getting this arrhythmia again and again. Patient is getting ventricular arrhythmia again and again. You have tried to give adrenaline, but patient is getting arrhythmia again and again. Now, what is the which anti-arrhythmic drug we will give over here? So, who will tell me what is the drug of choice for ventricular arrhythmia? So, the drug of choice for ventricle arrhythmia, because the patient is suffering from ventricle type of arrhythmia. So, the drug of choice for ventricle arrhythmia is amiodarone. So, here you will give amiodarone to a patient. The first dose of amiodarone is 300 milligram. The second dose of amiodarone is 150 milligram. If amiodarone is not given in MCQ, you can also give lidocaine for the ventricle fibrillation. You can also give lidocaine as a drug for ventricular fibrillation. So lidocaine can also be given as a drug for ventricular fibrillation. So what is the dose of lidocaine? The dose of lidocaine is First dose is approximately 100 milligram. Second dose is approximately 50 milligram. So amiodarone is a medicine that is a first antiarrhythmic to be given. In case it is not available, you can also give lidocaine to a patient. The first dose 100 milligram, the second dose 50 milligram, that we have already covered. This is for the ventricle fibrillation. Now, if any patient comes to you with non-shockable rhythm, if any patient comes to you with non-shockable rhythm and patient is suffering from cardiac arrest, then the patient presentation is asystole. So patient will come to you with zero systole. So patient will come to you with asystole. And the second is the patient can come to you with pulseless electrical activity. So patient will come to you with pulseless electrical activity. So patient will come to you with asystole and patient will have the pulseless electrical activity. So there are two presentations, asystole and pulseless electrical activity. So here you only do the CPR 2 times. Here you will not give any shock. You will only do the CPR 2 times. And after giving the CPR, if the patient is not revived, you will give adrenaline to this patient. You will give adrenaline to a patient with the same dose, same concentration, same volume and everything, right? So this is how we manage a patient of cardiac arrest. This is how we manage a patient of cardiac arrest. Now the third presentation is the patient can come to you with tachycardia. So patient can come to you with tachycardia. So patient heartbeat more than 120. So patient will have more than 120 beats per minute with symptoms. Or if the patient is getting heartbeat more than 150 beats per minute with or without symptoms, we need to treat the patient. So more than 120 beats per minute with symptoms, more than 150 beats per minute with or without symptoms, we have to treat the patient. So patient has got tachycardia. Now what is the basic problem here? The basic problem is when the patient has got tachycardia, the SA node is overactive. Like this is the heart. If I say this is the heart. So here in this case, I will say the SA node. So the patient SA node is overactive. Now SA node is giving the signal excessively. Now if the signal will reach the ventricle, if the signal of SA node will reach the ventricle with the same speed by which the SA node is giving the stimulus, this phenomena is known as paroxysmal phenomena. Because till the time the tachycardia is present above the ventricle, till the time the problem is present supraventricularly. So till the time the problem is present supraventricle, then then there is no issue. Like then there is no issue. The patient is not going to die. But when this problem will reach the ventricle, so when this problem will reach the ventricle, then the patient cardiac output get compromised, and this phenomena is known as paroxysmal phenomena, and this complication is known as paroxysmal supraventricular tachycardia. So paroxysmal means when something is taking place very fast. When something is taking place very fast, so we call it paroxysmal supraventricular tachycardia. Right? Doctor, how to give shock? This will be covered in your anesthesia class, Dr. Snehaja. As far as I know, here the shock meaning that you have to only synchronize the patient. You are not supposed to defibrillate the patient. You will synchronize the patient. So here you synchronize the patient. Here the purpose of giving shock is to synchronize, right? So this will be covered in your medicine class or maybe in anesthesia class. How much shock, like 300 joules total we give. So how to give this 300 joules, that will be discussed with your defibrillator machine, right? So whosoever will teach you about the defibrillators, then that faculty will teach you how to synchronize the patient here, right? So regarding the drugs, I have told you adrenaline is a drug of choice, right? So PSVT is a condition which is best managed by giving a drug that is known as adenosine. So adenosine is a drug which is a overall best medicine for this condition. So adenosine is a medicine that we will use in this patient. And adenosine, when given to a patient, this medicine is given as a first dose 6 milligram. Second dose is given as 12 milligram. First dose 6 milligram, second dose 12 milligram. Adenosine is given, right? So 6 milligram followed by 12 milligram is given. So adenosine is always given by IV bolus. Adenosine is always given by IV bolus. So we always give the medicine in a higher dose. In one go, in one shot, we will give the full dose. And this IV bolus is immediately followed by the saline push. So this IV bolus is immediately followed by the saline push. So this IV bolus is immediately followed by saline push. So you'll give the IV bolus and this is immediately followed by the saline push. The drug name is adenosine. 6 milligram is given followed by 12 milligram. IV bolus is given followed by the saline push. Now guys, who will tell me which particular veins are preferred, the central veins or the peripheral veins? So the answer is we always prefer to give medicines in central vein. So try to give medicines in central veins. In case it is not possible, give the medicine in peripheral veins, right? So always try to give medicines in central vein because this medicine metabolism is very fast. This medicine metabolism is very fast. So this drug is metabolized in RBC and the medicine half-life is only 10 seconds. So medicine half-life is only 10 seconds. The drug is rapidly metabolized by RBC within 10 seconds. Right? So medicine half-life is 10 seconds. Always give medicines in the central vein. Yes, because of the short half-life, we always try to give medicines in central vein. The drug name is adenosine that is used. So this is the drug. This is the drug that we use for PSVT. So these are the four algorithms of ACLS that the medical part, the drug part we have discussed over here. The shock part, like how to give shock, how to give CPR, this will be covered in your anesthesia class. How much current is given, what are precautions we need to take. So all these things will be covered in your anesthesia class, right? Now guys, apart from this ACLS, if the question comes on any type of shock, so if the question comes on any type of shock, so please remember drug of choice for all type of shock. Drug of choice for all type of shock that you need to mark is noradrenaline. So noradrenaline is a drug of choice for all type of shock followed by dopamine. So noradrenaline is a drug of choice for all type of shock followed by dopamine. Now, what is the dose of dopamine? Guys, please remember the dose of the dopamine is always more than 10 microgram per kg per minute. So dose of the dopamine is always more than 10 microgram per kg per minute. So whenever any patient of shock comes to you, drug of choice noradrenaline, the second drug of choice dopamine, but that need to be given in a dose more than 10 microgram per kg per minute. But there are three exceptions to this rule. There are three exceptions to this rule. What are the three exceptions? The first exception is when any patient suffer from anaphylactic shock. When any patient suffer from anaphylactic shock, instead of noradrenaline, some other medicine is drug of choice. So instead of noradrenaline, other medicine is the drug of choice, right? Now second exception is when any patient suffer from cardiogenic shock. When any patient suffer from cardiogenic shock, the other medicine is a drug of choice. And when patients suffer from cardiogenic shock, patients suffer from cardiogenic shock with oliguria, some other medicine is a drug of choice. Now this you people have to answer me. When the patient suffer from anaphylactic shock, which drug is drug of choice? When the patient suffer from cardiogenic shock with systolic blood pressure more than 90, we call it maintained BP. And the patient suffer from cardiogenic shock with oliguria, then which medicine is drug of choice? Who will answer me this question? What is the drug of choice for anaphylactic shock? Drug of choice for cardiogenic shock with maintained BP? Drug of choice for cardiogenic shock with oliguria? Very good. So here you will mark the answer as adrenaline. So here the drug of choice is adrenaline. So adrenaline is a medicine which is a drug of choice for anaphylactic shock. So here guys, again you people have to answer me four questions. What is the dose of the medicine? What is the concentration of medicine? What is the volume of the medicine that you will inject? And what is the route of administration? So four questions you have to answer me regarding the drug adrenaline that is useful for anaphylactic shock. What is the dose? What is the concentration? What is the volume? What is the route? Right? Yes. In Dr. Sneha has given the correct answer. Pianchi also has given the correct answer. In patients of cardiogenic shock with oliguria, you will mark dopamine as the drug of choice. You will mark dopamine as the drug of choice. But guys, who will tell me the dose of the medicine? What is the dose of the medicine when I use this medicine for cardiogenic shock with oliguria? So cardiogenic shock with oliguria, what is the dose of the dopamine? And also you people have to answer me, what is the best medicine for cardiogenic shock with maintained BP? Systolic blood pressure more than 90. Yes, so here the answer is dobutamine. So dobutamine is a drug which is a overall drug of choice. So dobutamine, which is a beta 1 receptor agonist, this is a drug of choice for cardiogenic shock with maintained blood pressure. Yes. So now you people have given the correct answer. Here the dose of the medicine is half of the cardiac arrest dose. So the dose of the cardiac arrest was 1 mg. Here the dose is 0.5 mg. Here the dose is 0.5 mg. Concentration is 1:1000. concentration is 1:1000, right? And the volume of the drug is 0.5 ml, because this 1:1000 contains 1 milligram drug per ml. This contains 1 milligram per ml. So when you want to give 0.5 mg, you have to give 0.5 ml. Now, what is the route of administration? The best route is intramuscular route. The best route is intramuscular route. Now, who will tell me which muscle? Which muscle is the best muscle to give the injection? The answer is the best muscle to give the injection is vastus lateralis. So best muscle to give the injection is vastus lateralis. So adrenaline can be given in a vastus lateralis, that is a thigh muscle. This is the best muscle to give the injection. Right? Now guys, if your patient is stable, you can also give medicine by subcutaneous route. So in a stable patient, you can also give medicines by subcutaneous route. The only problem is the absorption is slow, right? The only problem is the absorption is a bit slow, but it's fine when the patient is stable. Now, if you want to give medicine by IV route, when you want to give medicine by IV route, when you want to give medicine by IV route in anaphylactic shock, please remember the dose need to be decreased, because IV route has very fast onset of action. So IV route has very fast onset of action. So IV route has very fast onset of action, and therefore, whenever you want to give medicine by IV route, whenever you want to give medicines by IV route, the dose need to be decreased a lot. So here the dose should be only 0.1 mg. You get the dose. You have made the dose 1/5. So you will give the medicine dose 1/5 of the normal dose. So normal dose 0.5 mg. Here we give the dose 0.1 mg. Now, whenever we have to give 0.1 mg of the dose, we have to use the concentration 1:10,000. We have to use the concentration 1:10,000, and the volume of the drug that I will inject is equal to 1 ml. You can see from the above photograph, you can see 0.1 mg drug present in 1 ml. So we have to give total 1 ml of the drug. So here the volume is 1 ml. So here the volume is 1 ml that we need to inject in a patient. So route is IV, dose is 0.1 mg, concentration 1:10,000, the volume is 1 ml. This is how we give the medicines to our patients. Right? Now guys, who will tell me in patients of anaphylactic shock? In patients of anaphylactic shock, what are the other drugs? What are the other drugs that we can use in patients of anaphylactic shock? So can you name some medicines which you have practically used in your day-to-day practice? So when any patient of allergy, any patient of drug allergy comes to you, what are the other medicines that we use apart from adrenaline? Because guys, I know that adrenaline is a drug that is only be given when the patient will come to us in shock, like patient has gone into the shock. But if the patient has got mild allergy, if the patient has got only mild allergy, now which medicines, which are the other medicines that we can use in patients of anaphylactic shock? Yes. So all of you have given the correct answer. Other medicines that we can use in the patient treatment are antihistaminic medicines. We can also give steroids. So antihistaminics we can use, steroids we can use. So steroids can decrease the level of IgE. Antihistaminics will counter the effect of histamine, and we can also use salbutamol. We can also use salbutamol as a bronchodilator. So salbutamol can be used as a bronchodilator. So these are the other medicines that we can use in patients of anaphylaxis or any type of allergy. Right? Next is dopamine. So here the dose of the dopamine is also important. So what is the dose of the dopamine that we use in cardiogenic shock with oliguria? So here the dose of the dopamine is between 2 to 10. Between 2 to 10 microgram per kg per minute. So here the dose of the medicine is between 2 to 10 microgram per kg per minute. So in this dose, this medicine can act on D1 receptor, as well as this medicine will act on beta 1 receptor. So by acting on D1 receptor, this medicine can increase GFR. By acting on beta 1 receptor, the medicine can increase cardiac output. So I can use this medicine in a dose 2 to 10 microgram per kg per minute, and this is sufficient to manage this patient of cardiogenic shock with oliguria. So this topic is over. We have covered the various types of medical emergencies. So various types of medical emergencies we people have covered. So question number 2, answer is C. Now question number 3. Question number 3, a patient, a 5-year-old boy went to the temple. Actually, this question was asked in AIMS exam last year. And according to the question, the patient went to Shiva temple. So 5-year-old boy went to some Shiva temple in a village with his grandmother. Now he was crying inconsolably. So he was crying a lot on his way back. Taken to the emergency department within 3 hours, still he was crying. So he was having the altered sensorium, increased salivation, cold clammy skin, excessive sweating. He was pale, having the priapism. BP is towards the higher side. BP is high. For kid, it is very high. Heart rate is also very high. Tachypnea is there. Oxygen level is fine. So which of the following would you use in this management? So any idea, guys, what is this problem? Sneha, dose of dobutamine is not important. Dose of dobutamine is not important. It is approximately 10 to 15 microgram. It is approximately 10 to 15 microgram per kg. So that's not important. So the dose of dopamine is important. Dose of dopamine is important, not the dobutamine, right? So question number 3, what is the case, guys? So guys, please remember, they have confused you by giving that patient has gone to Shiva temple. So most of the student thought the patient has got snake bite, but it is not a case of snake bite. Although Shiva has the snake around his neck, but it is not the case of snake bite. It is a case of scorpion bite. So this is a case of scorpion bite, right? So in question 3, patient has got scorpion bite. So in scorpion bite, a lot of noradrenaline and acetylcholine released in the patient body. So noradrenaline and acetylcholine both are released in the patient body whenever patient is bitten by scorpio. And because of this acetylcholine, the child is having the parasympathetic symptoms like the salivation is there, secretions are there. Patient has got priapism. So patient has got priapism, secretions and salivation. And because of this noradrenaline, the child is having the hypertension, the child is having the tachycardia. So all those symptoms are due to the sympathetic effect. So both sympathetic and the parasympathetic effects are there, right? So whenever the patient is bitten by this poisonous insect, that is scorpio, so you have to give antivenom first. You have to give the antivenom first. Now after giving the antivenom, if the patient BP is still high, if the patient blood pressure is still high after giving the antivenom, then you have to give the prazosin. You have to give the prazosin to this patient if the BP is still high, right? So you give antivenom first, and if the BP is still high after giving antivenom, you will give prazosin. For rest of the symptoms, we don't give any medicine. Rest of the symptoms automatically subside. Rest of the symptoms automatically subside because you have given the antivenom that is sufficient to stop the action of the scorpion venom. Now, guys, after this scorpion venom management, who will tell me how to manage the cobra bite? So whenever patient is bitten by cobra snake, now cobra bite is a neurotoxic snake. This is a neurotoxic snake, the cobra bite. Now here the patient neuromuscular junction is blocked. Patient neuromuscular junction is blocked and patient will come to you with muscle weakness. So patient will come to you with muscle weakness after cobra bite. So which medicine you will give first? Answer is we will give the anti-snake venom. We will give the anti-snake venom first. And after giving the anti-snake venom, if you want the fast recovery, if you want the fast recovery of the patient after giving anti-snake venom, then you can give the combination of atropine plus neostigmine. So atropine plus neostigmine combination is given if you want the fast recovery. Otherwise, anti-snake venom will take care of this. So anti-snake venom is the first thing to give. And if you want the fast recovery, you will also give atropine plus neostigmine combination in patients of cobra bite. So in patients of cobra bite, you will give this combination. Now, third is the patient can come to you with organophosphate poisoning. So, the patient will come to you with organophosphate poisoning. So, how will you manage this organophosphate poisoning? Can any one of you answer? If the patient has come to you with organophosphate poisoning, which antidote is given? So, in organophosphate poisoning, acetylcholine level is very high in the patient body. So, this is cholinergic poisoning. So this poisoning is known as cholinergic poisoning. Here the acetylcholine level is high. We call it organophosphate poisoning because patient acetylcholine esterase enzyme is irreversibly blocked. So acetylcholine esterase is irreversibly blocked. Patient will get cholinergic poisoning. So which medicines we give? Yes, we give atropine as an antidote. Atropine is given as an antidote, but along with atropine, we always give one more drug. We always give one more drug along with atropine. The name of the group is oximes. So along with atropine, we always give oximes. So oximes may lead to fast recovery. So oximes may result in fast recovery. So this will result in fast recovery if they are given or if they are injected well before time. So if they are given in a well stipulated time, then the recovery will be faster. Otherwise, oximes not have much role in OP poisoning. Okay. Next is patient can come to you with atropine poisoning. So if the patient has come to you with atropine poisoning, which is also known as belladonna poisoning. So atropine poisoning, belladonna poisoning, datura poisoning. So atropine poisoning, belladonna poisoning, datura poisoning. So patient will have the anticholinergic symptoms. So patient can have the anticholinergic symptoms because of this poisoning. So patient can have anticholinergic symptoms because of this atropine, belladonna, and the datura poisoning. So patient can have anticholinergic symptoms like the patient can have dry mouth, dry eyes. Patient can have hyperthermia. So patient can have hyperthermia. Patient can have mydriasis. So these are the anticholinergic symptoms. So you have to give the antidote. So I can see most of you have given the correct answer. The antidote of choice is physostigmine. So physostigmine is the antidote of choice. There is no need to give any other drug. Physostigmine is a wonderful antidote of atropine, belladonna, and the datura poisoning. Right, guys? So these are the some important poisonings that we people mostly cover in autonomic nervous system. One more thing, in case you can remember, guys, do you know like local anesthetic drugs? Local anesthetic drugs are given in combination with adrenaline. They are given in combination with adrenaline, where we give this medicines in dilution of lakhs, right? 1:lakhs. This can be 2 lakh, this can be 4 lakh, this can be 6 lakhs, which can be 8 lakh. So here the role of the adrenaline will act as a vasopressor. So this will cause vasoconstriction when you give along with local anesthetic drug. So if there is a extravasation, of adrenaline from the site of injection, this can result in massive vasospasm. This can result in massive vasospasm and can result in gangrene also. So who will tell me which antidote we can give? Right? So what is the name of the antidote that we can use in a patient of uh, used in a patient who is getting gangrene or the vasospasm because of the extravasation of adrenaline from the site of injection. So here the antidote of choice is an alpha blocker. The alpha blocker name is phentolamine. So phentolamine is a name of an alpha blocker. So phentolamine is a vasodilator. It's an alpha blocker. So this is the medicine which is a drug of choice for or antidote of choice for vasospasm or the gangrene that can occur when the adrenaline is extravasated to other parts of the body and can lead to vasospasm. Right? Yes, alpha blocker, phentolamine can be used. Dr. Nitin has asked about the mushroom poisoning. Dr. Nitin, actually mushroom poisoning does not happen in India. That's why the questions are mostly not asked on mushroom poisoning. There was a time in Europe, particularly in Germany. Germany was the country, Germany and Spain. Have you ever been to Germany and Spain? So there the toxic mushroom, poisonous mushrooms were grown and those used to cause a mushroom poisoning. ठीक है तो आज की डेट में we don't find the cases of mushroom poisoning. So mushroom poisoning, muscarinic receptor. We know that the muscarinic word has come from colorful mushroom. Muscarinic word has come from colorful mushroom. So muscarinic receptor is overstimulated. Muscarinic receptor is overstimulated. So we have to give a anticholinergic drug atropine. So we have to give atropine as a drug to the patient. But we have the other types of mushroom poisoning where the patient will have the totally different type of symptoms. So for other type of mushroom poisoning, we don't have any antidote. We don't have any other antidote, so we only give the symptomatic treatment. So if the mushroom poisoning is causing the parasympathetic symptoms, patient is having the parasympathetic symptoms due to the mushroom poisoning, that is a muscarinic poisoning, right? So there we give atropine. Otherwise, for all other mushroom poisoning, we don't have any antidote. We only give the symptomatic treatment. But guys, let me tell you, in last 15-20 years, there is no question for mushroom poisoning. So better to leave this topic because we don't find such cases in India. So coming back to the question number 3. So in this patient, we will give antivenom first. We will give antivenom first in this patient, then we give prazosin in case the BP is high. So question 3, answer is A. Now question number 4. A patient presented with hyperkalemia. Patient presented with hyperkalemia. So which drug can be used that will decrease the extracellular potassium level? So which medicine can decrease the extracellular potassium level in this patient? So who will tell me what is the name of the drug? So question number 4, again a difficult question asked in AIMS exam. So here the answer is epinephrine. So epinephrine is a drug which is given for hyperkalemia. So epinephrine is a medicine that is given for hyperkalemia. So this question is based on adrenaline or the epinephrine indications. So what are the indications of adrenaline or the epinephrine? So 3 indications we people have already covered. 3 indications we people have already covered. Like I can use this medicine for the treatment of anaphylaxis. I can use this medicine for the treatment of anaphylaxis in concentration 1:1000. It's a drug of choice for anaphylactic shock. This we have already covered. Now this is also drug of choice for cardiac arrest. This also we have covered. We use the medicine concentration 1:10,000. So patient has shockable or the non-shockable type of rhythm. This is a drug of choice for cardiac arrest. Now this medicine is also given along with local anesthetic drug. This medicine can be given along with local anesthetic drugs, but the concentration is very diluted. It can be 2 lakh, 4 lakh, 5 lakh, sorry, 2 lakh, 4 lakh, 6 lakhs or 8 lakhs. So different types of formulations are there, that is in lakhs along with local anesthetics. Now apart from these 3 main indications, where else we can use adrenaline? So guys, please remember adrenaline is a drug which is also used as an anti-glaucoma drug. We can also use this medicine as an anti-glaucoma drug. So medicine is used as an anti-glaucoma drug with the name of dipivefrin. So this medicine can be used as an anti-glaucoma drug with the name of dipivefrin. Now this medicine we have already covered is also given for the treatment of bradycardia. So the treatment of bradycardia, if the atropine is not able to control, if atropine is not able to control the bradycardia, this medicine can be given after atropine. So after atropine in the treatment of bradycardia, adrenaline or dopamine can be given for the treatment of bradycardia. Right? So fifth indication of the medicine is bradycardia. Now this medicine is also given for the treatment of status asthmaticus. Medicine is given for the treatment of status asthmaticus. Now in treatment of status asthmaticus, we can give this medicine by subcutaneous route. So 1:1000 is the concentration, 0.5 mg is a dose that can be given by subcutaneous route. But in treatment of status asthmaticus, I can also use this medicine by inhalational route. And when we use this medicine by inhalational route, I will use its concentration as 1:100. So by inhalational route, this can be given by in concentration 1:100. Subcutaneous route for status asthmaticus 0.5 mg, 1:1000 is the concentration. Now this medicine is also given for the treatment of epistaxis. Medicine is also given for the treatment of epistaxis by local route. It is given by the local route for the treatment of epistaxis. The concentration of the drug is 1:1000. So 1:1000 is a concentration when I can use this medicine as a drug for vasospasm, vasoconstriction that will stop the bleeding. So medicine is given for epistaxis. Right? Now, apart from this, this medicine has one more rare indication, hyperkalemia. So this medicine can be given for the treatment of hyperkalemia. So in treatment of hyperkalemia, this medicine can stimulate beta-2 receptor. So by acting on beta-2 receptor, this medicine can stimulate sodium potassium ATPase pump. So medicine can stimulate sodium potassium ATPase pump, which is present on the surface of muscles. So the surface of muscles, we can stimulate sodium potassium ATPase pump by stimulating beta 2 receptor, and this can push all the potassium. This can push all the potassium inside the muscle. This will lead to potassium entry inside the skeletal muscles. So potassium will take entry inside the muscle by stimulating sodium potassium ATPase pump. That's why this medicine is given for the treatment of hyperkalemia. So medicine is also given for the treatment of hyperkalemia. So these are the indications of adrenaline. Apart from these indications, you should also be knowing one animal experiment that is also associated with the use of adrenaline. The name of the experiment is Dale vasomotor reversal. So Dale vasomotor reversal. So Dale vasomotor reversal is the name of experiment that is done on animals, right? That is also associated with adrenaline. And this experiment is done for the discovery of beta 2 receptor. With the help of this experiment, we could able to discover beta 2 receptor. So these are the indications of adrenaline as a drug. Right, guys? So this question is based on the medicines which are given for hyperkalemia. So epinephrine is a drug which is given for the treatment of hyperkalemia. So guys, if any patient comes to you with acute hyperkalemia, and you are getting some ECG changes, now which medicine will you inject? Which medicine will you inject so that the cardiac membrane gets stabilized? So that the cardiac membrane gets stabilized and patient will not get the cardiac complication. So which medicine is given as a drug of choice to stabilize the cardiac membrane in patients of hyperkalemia? So in patients of hyperkalemia, what is the name of a drug that you can give to a patient if the patient is getting ECG changes and you don't want that patient get heart block or patient get any complication? Yes, so Dr. Priyanshi has given the correct answer. We will give calcium gluconate to the patient. So calcium gluconate is a medicine that is given to stabilize the cardiac membrane. But along with calcium gluconate, which medicine is given to reduce the level of potassium in plasma? So what is the name of the drug that is given to reduce the level of potassium in plasma? The name of the drug is insulin. So insulin is a drug which is given to the patient by IV route along with the dextrose. So along with the dextrose, we will give insulin to the patient. Now insulin will also stimulate the same pump. Insulin will also stimulate the same pump just like epinephrine and can shift all the potassium inside the cell. So treatment of hyperkalemia, for ECG changes, we give calcium gluconate, and for reducing it potassium level in plasma, we will give insulin. Now guys, in this patient, when we give DNS along with insulin so that the patient will not develop hypoglycemia. We don't want that patient to develop hypoglycemia. We give dextrose normal saline, right? Now this can result in fluid overload. This can result in fluid overload in this patient because patient is not suffering from dehydration. Patient was already having the normal fluid that will lead to fluid overload. So here we can also give a drug furosemide. Here we can also give a medicine furosemide. So furosemide is a diuretic that will also result in loss of potassium as well as this will result in loss of water from the body. So this will take care of the fluid overload. So furosemide will also cause loss of potassium. So side effect of furosemide is potassium loss. So here we want the loss of potassium. So this medicine can also lead to fast loss of potassium, plus this will cause water loss. So whatever extra fluid we will gain in DNS, so that dextrose normal saline, that the fluid is lost by giving the furosemide, so the balance is maintained. Right? Now, apart from this furosemide, we can also use the other medicines like we have the potassium binding agents. We have some potassium binding agents that we can use. We can also use a medicine like salbutamol. We can also use this medicine like epinephrine. So epinephrine, salbutamol, they will also act like uh, insulin. So they also stimulate sodium potassium ATPase pump. So these medicines can be given for this condition. Potassium binding agents can be used, but not very useful. So three medicines are the main drugs that we use in hyperkalemia. One is calcium gluconate, second is insulin, third is a furosemide. Three medicines mainly we use for hyperkalemia. Other medicines are potassium binding agents and salbutamol and epinephrine. Right? So these are the drugs that we can use for hyperkalemia. Now, question number 4 we people have covered. The answer is C, epinephrine. Now let's move on to question number 5. Which of the following drug will worsen the myasthenia gravis? So which condition can worsen myasthenia gravis? So guys, please remember, myasthenia means muscle. Myasthenia means muscles. Gravis means graveyard. So patient muscles are in graveyard. Patient muscles are in graveyard. Patient will have the muscle weakness, myasthenia gravis. So which medicines can worsen the condition? So the answer is any drug which is blocker of neuromuscular junction. Any medicine blocker of neuromuscular junction can worsen the scenario. So any medicine that is neuromuscular junction blocker can worsen the scenario. So question number 5, what is the best answer? Which you people know? Yes. So answer is Dr. Soma Shubhra has given the correct answer. Answer is A. Answer is A, lidocaine and quinidine. So lidocaine and quinidine are two medicines which can worsen myasthenia gravis. So question number 5 is based on a condition, that is myasthenia gravis. So if any patient of myasthenia gravis will come to you, so which medicines are avoided? First of all, we will discuss the drugs which are avoided. So medicines which are avoided in patients of myasthenia gravis. Number 1, so all drugs of anesthesia. So all drugs that we used during anesthesia, all medicines are contraindicated. So all medicines are avoided in patients of myasthenia gravis that we used in anesthesia. So these medicines can be local anesthetics. These medicines can be general anesthetics. These medicines can be skeletal muscle relaxants. So local anesthetics, general anesthetics, skeletal muscle relaxants, all these medicines we use during anesthesia. So these medicines are avoided during myasthenia gravis. Number 2, we have some antibiotics like aminoglycosides. So aminoglycosides are the antibiotics like streptomycin, gentamicin. So streptomycin, gentamicin are the antibiotics which are avoided in myasthenia gravis. Right? We have the medicines which are avoided in myasthenia gravis like Botox. So Botox is a drug. Botox is a drug that can cause blocking of neuromuscular junction, can result in muscle weakness. Medicines can be beta blockers. So medicines can be beta blockers. So beta blockers, by blocking the beta receptor, they can reduce the level of cyclic AMP in muscles. And when they reduce the level of cyclic AMP in muscles, muscles become weak. Muscles become weak. Fifth is calcium channel blocker. So medicines which are calcium channel blocker, they can stop the calcium entry in muscles. When the calcium cannot take entry in muscles, muscles cannot contract. Sixth medicine is magnesium sulfate. So guys, please remember, body cannot differentiate between calcium and the magnesium ion. So body cannot differentiate between magnesium and the calcium ion. So whenever we give magnesium sulfate to a patient, like we use in eclampsia, like when we give this medicine to pregnant female, female deep tendon reflex, female deep tendon reflex is gone. So body cannot differentiate between calcium and magnesium. So when you give magnesium from outside, this will block the calcium entry in muscles. So magnesium will go and occupy the calcium channel. And once it will occupy the calcium channel, this will stop the calcium entry in the muscles. Now the seventh medicine that we should avoid in a patient is the medicines that start from alphabet Q. So these medicines are like quinine, anti-malarial drug, we have an anti-arrhythmic drug quinidine, and we have an fluoroquinolones. So we call them quinolones, fluoroquinolones. So we have quinine, quinidine, and quinolones. So these medicines are avoided in patients of myasthenia gravis. And guys, in case you can write down the medicines which are known as immune checkpoint inhibitors. So medicines which are known as immune checkpoint inhibitors. Now, immune checkpoint inhibitors are those drugs which can activate the body immunity. So these are the medicines which will activate the body immunity against the cancer. So these medicines are the one, they can stop the checkpoints of the immunity and will activate the immunity against the cancer. So one of the drug is like pembrolizumab. So one of the medicine is like pembrolizumab. So this medicine can activate the immune system against the cancer cell. So immune checkpoint inhibitors are also avoided in patients of myasthenia gravis. So guys, I don't have any good mnemonic for you, but still I can give you one shortcut. So two medicines starts with A, two medicines starts with B, and two medicines are blocker of calcium. So two medicines starts with A, all drugs of anesthesia. So A means anesthesia, aminoglycoside. B stands for Botox and beta blocker. C stands for calcium channel blocker and the drug which resemble calcium, that is magnesium. And we have some medicines which start from alphabet Q. Three medicines start from alphabet Q. So this is how we can remember the drug names which are avoided in myasthenia gravis. Now, if the question is asked to you, how we treat a patient of myasthenia gravis. So who will tell me what is the drug of choice for myasthenia gravis? What is the name of a drug that is used for myasthenia gravis? So what is the drug of choice for myasthenia gravis? Till that time, I will have some water. So myasthenia gravis, whenever the patient will come to us, drug of choice is pyridostigmine. So pyridostigmine is the medicine that is a drug of choice. So pyridostigmine is a medicine that is a drug of choice for myasthenia gravis. In case pyridostigmine is not given in MCQ, you can also mark neostigmine. So pyridostigmine and neostigmine are the drug of choice, and these medicines are always given with low dose of atropine. So these medicines are always given with low dose of atropine. Now, when these medicines are not able to control, when these medicines are not able to control the myasthenia gravis, when these medicines are not able to control myasthenia gravis, yes, they are always given with low dose of atropine. So if these medicines are not able to control myasthenia gravis, we will add immunosuppressants. So in the treatment of the patient, we will add immunosuppressant medicines. So we will add immunosuppressant medicines if the patient condition is not controlled. So now they will ask you which immunosuppressants we can add. So we can add the immunosuppressants as azathioprine. So azathioprine, we can add cyclosporin. So azathioprine, cyclosporin, mycophenolate. So these are the three medicines. These are the names of three immunosuppressant that we can add in the patient treatment. Azathioprine, cyclosporin, mycophenolate. So these immunosuppressants are added. We can also add we can also add steroids, but steroids are generally avoided because the long-term side effect of steroid therapy is muscle atrophy. So muscle atrophy is a long-term side effect of steroid therapy. So in this patient where the muscles are already compromised, here the patient muscles are already compromised. So generally we don't prefer to give steroids for a long-term therapy in patients of myasthenia gravis because here the muscles are already compromised, right? Now, this is the treatment for myasthenia gravis. Now, guys, please remember if the patient has come to you with myasthenia crisis, the second presentation, the patient may come to you with myasthenia crisis. So, the above patient has come to us in OPD. So, OPD treatment we have discussed when the patient is stable, but when the patient is unstable, when patients of myasthenia crisis, patient is unstable. So in myasthenia crisis, in unstable patients, how we take out the antibodies. So here our basic purpose is to remove antibodies. So how we can remove antibodies from the patient plasma? So we can remove antibodies from patient plasma. Guys, give me 1 minute. I'm getting a phone call. Hello. Yes, guys. So I'm so sorry for this interruption. Right. So myasthenia crisis, we have to remove antibodies immediately. So we can go for plasmapheresis. So plasmapheresis we can go for. And in case plasmapheresis is not available, we can also go for intravenous immunoglobulins. We can also go for intravenous immunoglobulin, and we can also give short course of steroids. So IV route say we can also give methyl prednisolone. So we can also give methyl prednisolone to a patient by IV route. So we can give methylprednisolone as a drug by IV route. We can also give intravenous immunoglobulin. We can also go for plasmapheresis. Three things we can do for this patient of myasthenia crisis. But guys, please remember, in patients of myasthenia gravis, the question which they will put you have to be very careful that you have to stop the pyridostigmine. So while treating patient of myasthenia crisis, you have to stop the patient of, you have to stop pyridostigmine, or you have to stop that thing, I mean, new stigmin. So if the pyridostigmine or new stigmin is already going on, you have to stop the medicines, right? So these medicines have no role in the treatment. Guys, again, I'm getting a same phone call. Wait. So we people have discussed the detailed treatment of myasthenia gravis along with the medicines that we should avoid in patients of myasthenia gravis. Now, question number 6. A patient comes to you with acute glaucoma and red eye. Intraocular pressure is 38 and anterior chamber shows aqueous flare and keratic precipitate. So which drug is not given? Any idea, guys? What is this problem and which medicine we should avoid? Yes. Sneha, in patients of myasthenia crisis, if I give pyridostigmine and neostigmine, studies have shown that these medicines are the cholinergic drug. They can further cause more reduction of blood pressure, more reduction of the heart rate, which are the cholinergic side effects. So those things will deteriorate the scenario. Because if I give pyridostigmine, that is not going to produce much benefit to the patient in acute cases, right? Rather, these medicines will deteriorate the scenario. That's why I said that you should avoid or you should stop giving pyridostigmine and neostigmine. These medicines have no role. So these medicines have no role in the treatment, right? Yes, here the answer is prostaglandin analog. So here the answer is prostaglandin analog. So prostaglandin analogs are the anti-glaucoma drugs. They are the anti-glaucoma drugs which can result in inflammation in eyes, which can result in inflammation in eyes. And this patient is already having the anterior uveitis going on. So anterior uveitis is already there. That's why you will not give prostaglandins in this patient. So guys, in this MCQ, we can discuss the treatment of glaucoma. So if the patient of open angle glaucoma, if the patient of open angle glaucoma will come to you, so this patient will always come to an OPD because in open angle glaucoma, we don't have any acute attack. In open angle glaucoma, we don't have any acute attack. Patient always comes to us in OPD. Guys, give me 1 minute. Actually, I'm getting the phone call again and again. I'm so sorry for that. So patient of open angle glaucoma will come to an OPD. or the second patient is patient of angle closure glaucoma, and he has undergone the surgery. He has undergone surgery of the angle. So post-operatively. This patient has come to you for follow-up. So this patient has come to you for follow-up post-operatively.